Good day, I'm Jackie Judd. While there is great debate over how to fix the nation's healthcare system, there is widespread agreement that the way we pay for medical services needs to change. Providers and insurers alike are experimenting with new models of payment. What are they, and how may patient care be affected? Are questions Insuring Your Health columnist Michelle Andrews is here to help answer. Welcome.
Hello.
You've done a lot of reporting on the subject. You found a medical practice in Seattle, Washington, that basically turns the payment system on its head, the traditional payment system on its head. It's called Q-Liance. How does it work?
Well, the practice does not accept insurance and provides primary care services to many people for a monthly fee of about $70 for many folks. And so they get unlimited primary care from the practice. That would include in-office visits and any procedures that they get in the office, like, taking a cast off or stitches out. They pay extra if they need lab work done outside, that kind of thing. But basically they have a kind of all-you-can-eat model that they get for their primary care.
And how is this different from a boutique practice?
Well, boutique practices primarily are much more expensive. They can cost hundreds and hundreds of dollars a month, whereas this practice is often under $100 a month. In addition, boutique practices often take insurance, so there's a difference there too.
You interviewed the chief medical officer who said what we're inventing here is a new relationship between primary care and insurance. What did he mean by that?
Well, because they can do this with a monthly fee, they collect more from their their patients than they otherwise would if they were taking insurance, because they don't have that overhead, they don't have to worry about any of that. They can put that money back into the practice and have longer hours, that kind of thing. But the key here is, of course, that they don't take insurance, so patients can't use their insurance with that practice, and they then, we hope, need to carry catastrophic coverage for other kinds of care.
What do the critics say?
Well, people argue that this is really not a system that has legs, because it is, after all, outside of the insurance system, and they believe that there must be a way to provide this kind of good, coordinated primary care inside the system.
As you and I have talked about before, the healthcare overhaul law mandates certain preventive services be provided for covered individuals for free. So how does the practice you just described bump up against those new requirements?
Well, that's a question that some have raised, and I don't think there's an answer at this point, because you are paying a monthly fee for preventive services that under the law should be provided for free. So that would have to be worked out. However, the health reform law does have a provision in it that permits these kinds of practices to offer services in conjunction with insurance plans that are selling coverage through the health insurance exchanges. So there is some expectation that these kinds of practices can exist.
You've also looked into new models that insurers are testing. One in Minnesota, another in Massachusetts. What did you find?
Well, these kinds of models ask people who are members to pay more, basically, if they want to use particular providers who are considered high cost. It's not really a new thought, because these kinds of narrow networks, they're called sometimes, or select networks, preferred networks, are things that insurers and employers have experimented with for a while. But the hope is that you can sort of encourage people to use more cost-efficient providers and get good care for less money.
So these are doctors, they're hospitals
Exactly.
that would pretty much be off limits to people who have this coverage.
Yes, and some really notable institutions like the Mayo Clinic is one of the ones in Minnesota that's off the list for many people. And in Boston, we saw a lot of the Harvard teaching hospitals were off the list.
And yet many people, probably some even who are covered by these policies, would say, Mayo is the best. I want to go there.
Yes.
What options do they have?
Well, I think that they have an option oftentimes to pay more to use that facility. It's not always clear, depending on the plan, that you can't use the facility.
But
Many
there's a
times
premium.
you
You
pay
pay a
more.
premium.
Mm-hmm.
Is there anything out there on the horizon that you've seen that looks interesting in terms of these experiments with moving away from the traditional models that we're all really accustomed to at this point?
Well, what we're hearing so much about these days, are accountable care organizations, which are still sort of unicorns, and we don't really know exactly what they'll be like, but we're starting to see the outlines, and in those organizations, the groups of providers would come together to decide and agree to provide care for a group of patients, and they wouldn't get paid on this per procedure kind of basis that we currently pay providers. They'd get paid based on a group's health, and that would be very new.
I have to say, though, as you've been talking, some of what you've described reminds me of where HMOs were back in the 90s.
Mm-hmm. Yes, I think that there are many similarities, that you narrow the group of providers that people can use, and you pay them to take care of a person's health as opposed to,
And you pay a set fee.
You pay a set fee. I think that, there were many good things about those organizations, and unfortunately, the downsides for patients, there was a backlash.
Okay. Thank you so much. We'll see what's ahead. Michelle Andrews.
Thanks.